And I have the privilege of introducing our next speakers. So the talk now is on navigating acute mental health services in Durham Region and a practical guide for primary care. We have with us today Dr. Kevin Chopra. Kevin is the Chief of Psychiatry and Medical Director, Mental Health and Addictions Program at Lakeridge Health. He's also the Medical Director of General Psychiatry at Ontario Shores. Dr. Chopra has extensive clinical experience across many community and health settings, including Ontario Shores, the Centre for Addiction and Mental Health, the Department of National Defence at CFB Toronto, and community health centres. He completed his psychiatric residency training at the University of Toronto in 2005 and attained his PhD from the University of Toronto in 2013. He's an assistant professor at Queen's University and an associate clinical professor of psychiatry at the Medical University of the Americas in Denver, Massachusetts. So welcome to Dr. Chopra and Dr. Martins. So Dr. Jennifer Martins is a psychiatrist at Lakeridge Health Oshawa and also holds the position of division head for adult mental health and addictions at Lakeridge Health Oshawa, physician lead for clinical informatics and assistant professor at Queen's University Department of Psychiatry. Some of her interests include developmental disabilities, sleep, shared care, collaborative care, and medical education. Dr. Martins completed her Master's of Science degree in neuroscience before obtaining her MD degree and completing her residency training in psychiatry. And last but certainly not least for this panel is Beth Brannon. Beth is a registered nurse who has worked for over 30 years in the mental health and addiction sector and holds the position of Senior Director of Mental Health and Addictions at Lakeridge Health. Her portfolio currently includes the mental health inpatient and outpatient programs at Lakeridge Health, Pinewood Addiction Services, Distress Center Durham, and Durham Mental Health Services. So huge welcome to these three, and thank you so much for being here. We sincerely appreciate it, and I am going to turn it over to you to kick us off with the presentation today. Thank you.
Hi there. Good morning, everyone. I will, maybe before we go to the presentation, I'll just say a personal hello and then let Dr. Chopra and Dr. Martins do the same. So hi, everyone. I'm Beth Brannon. I'm the Senior Director for Mental Health and Addictions, and I'm really happy to be here with you today. Dr. Chopra?
Yes, pleasure to be here today. Look forward to our discussion.
Dr. Martins.
Good morning, everyone, and thanks for having us today. And also a special thank you to Shannon to kind of helping organizing all this and for having us present to you all. So thank you.
So I am going to get us started, and we'll just confirm that you are looking at a slide deck that says Lakeridge Health Mental Health and Addiction Services, not my emails or my chats or anything else. I hate it when that happens. All right. So super happy to be here with you today and share with you our amazing system of care at Lakeridge Health. I know many of you know us well. And I'm hoping that today you'll learn a few things about us that maybe you didn't know, and we can have a great conversation at the end about how we might be able to work better together, or if you have creative ideas, we're certainly here to listen. So happy to be here with you today. All right, so before I get into all of our services and the things that we do, I just wanted to start with an anchoring statement to say, you do not need to know all of these services. You do not need to know, I must remember to, refer to this service or refer to that service. You don't have to remember any of those things. At Lakeridge Health, we have one coordinated access point for everything across the entire mental health and addiction system that you're going to hear about today. So that access point is called Central Connect. It is a team of individuals who are trained to be able to match clients, patients to any number of services. So they can access and match people to Pinewood or to our outpatient services or to DMHS services, to outpatient psychiatry. So they can do all of that. And that service, Central Connect, is a lifespan service. So you don't need to remember one area for children and youth and one area for adults. Everything comes through Central Connect. I put a link here in the deck. I assume, Shannon, that we're sharing the decks after. Is that right? And follow up?
Yes, please. Yes, yes. Sharing the text. Thank you.
Beautiful. So the links will be there. You can also just, Google Lakeridge Health Central Connect or Lakeridge Health Mental Health and Addictions, and this information will pop up. So I just wanted you to know that that's there. There is a self-referral. There is also a provider referral, and you can find our referral forms through Oceans as well. So super easy access. We do our best at Lakeridge Health to be very low barrier. I think it's one of the lovely things that we learned from the addiction system is how important low barrier access is. And we're doing our best to do that. I did ask my Central Connect team in advance of this meeting, hey, we're talking with primary care and we have an opportunity to bend their ear a bit. Is there anything you'd like them to know? And they just said, no, we're super happy to take that navigation out of their hands, and super happy to help to navigate clients. They did say they really do prefer referrals through Oceans, if at all possible. That way we get, or the link on our Central Connect site. That way we get the information that we really need. We still do have kept all of our referral pathways open so that no one ever falls through the cracks, but that's the preferred method of referral. So so that's Central Connect, and we have lots of different folks who are part of that team, addictions counselors, child youth counselors, nurses, all kinds of different people who manage those referral processes. On average right now, most people are having a response from Central Connect within about 3 to 4 days. So there's very quick response from Central Connect to say, this is where we're going to connect you to. Those who are very urgent are often getting a same day response. So if I think about our, pregnant moms who are substance using, someone who's a high risk for suicide, that kind of thing, they're getting pulled very quickly and getting a quick connection to the services that they need. So really happy to share that information with you about Central Connect. And as a reminder, you don't have to remember all of the services I'm about to tell you about, and I'm super happy to share those with you. Kevin, Jen, anything you'd add around Central Connect?
Yeah, I would just highlight that one of the I think really great things about it too is the self-referral. So you could share this information to your patients. They could contact Central Connect and kind of figure out what they best need. And if they do need a psychiatric, consultation, then Central Connect would just say, go reach back, get a referral in and we'll connect you to make a psychiatric assessment. So sometimes a patient may not know what they need and we can help navigate it. So I think that's very helpful. And if you had certain numbers and they could give it a call. So I often use this for my patients as well, and they find it very helpful. And similar to the Ontario Structured Psychotherapy Program, that self-referral piece, I think really opens up access for our patients.
Perfect. Thanks, Kevin. All right, so I'm going to tell you a bit about who we are at Lakeridge Health. This is a slide just to tell you a bit about our reach. These are the some of the geographic locations that we have within Durham Region. We also have many, many locations that are available through partnership with other providers. So we are up in Brock. We do have services across the region through partnerships. So for most anybody, we should be able to serve their needs where they live, where they work, where they go to school. So it's a really large reach, and you'll hear more about that as I go through our services. So what does the mental health and addictions program look like at Lakeridge Health? We have, we have the second largest system of mental health and addictions care in Ontario. And that system has been evolved through an integration just over 5 years ago with Durham Mental Health Service and with the Distress Center Durham. So across all of our services, and I'm going to tell you about these in more detail, We have over 700 team members, including psychiatrists. We have psychologists, we have nurses, we have child youth workers, we have addictions counselors. We have a very large range, social workers, occupational therapists, a very, very large range of service providers across our system. We have more than 33 sites. We partner with more than 40 different organizations in partnership to provide care. I'm really happy to dive into each one of these categories with you. Many people prefer just kind of a one look. So if you were to take a snip that would give you an idea of all that we do, this would probably be the one that I would take if you want to have a quick reference. It gives you everything in one quick view, but I'm going to go through these in more detail. So one of the things that makes us really unique as a system of care is we do our very best to stay wrapped around what an individual needs. So by having within our service envelope inpatient care, outpatient care, emergency care, crisis beds, residential beds, addiction services, RAM, all of those things, by having all of those under one umbrella, it allows us to stay wrapped around an individual. I talked about that single access point that can come in, that central connect. We also have people who come in through our crisis teams. We have people who come in from our outreach teams. So that central connect team that I talked about earlier is not just those who process referrals in the moment. We have many of our outreach teams, our crisis teams are all trained on Central Connect too. So however a person comes into access with Lakeridge Health, we can grab them and get them connected to the right care at the right time. And that's really, really important to us. So you can see here, we wrap around the person. I'm going to tell you more about some of the work that we do. One of the unique things about our system of care is that we are all on one electronic health record. So regardless of whether somebody accesses care through DMHS, through Pinewood, through our outpatient programs, in our emergency departments, in our inpatient care, it is one electronic health record. Theoretically, people should not have to tell their story over and over again. It should be able to be told once, and our teams will leverage that. I'm going to be honest and say that that's something we continue to work on today. It's not perfect, and we really do our best to coordinate care around a person. We're just about 5 years, four and a half years into our epic journey. And it's an evolution, and we're learning together and really learning how we wrap around clients to provide coordinated care. The other really cool thing is we can actually start to pull data now around individuals and their care access patterns. So we look at some of our individuals who are repeatedly using our system of care, and we're now in a place where we can look at them and say, okay, this is interesting. You've accessed in the last 72 hours our ED, our crisis call diversion program, our mental health support unit, our crisis home, like, oh, yikes, what's going on? What do we need to do differently? And can put some care plans around those individuals. So we're early in that work, but I think it will be quite transformational. I was just going to tell myself that I needed the next slide, please. So I'm going to give you some detail. I'm not actually watching the chat. If there are questions, there, I'll have it up just in case. So in terms of crisis supports, I want to tell you a bit about the services that are available. So the Distress Center Durham, I hope all of you are familiar with the Distress Center Durham. It's located in Whitby, and they offer a volunteer line. It's a distress line, and I want to make sure it's clear that it's not a crisis line. So these are not professionals. It's answered by a volunteer service, and they do a wonderful job, especially for individuals who, maybe are experiencing some loneliness, need someone to talk to. It's a warm line. So the Distress Center Durham is always available to individuals. They are tightly connected as well with our Durham Mental Health Service call line, our crisis access linkage line. That is a 24/7 crisis line. Anybody at all can call anytime and speak to our crisis workers at Durham Mental Health Service. It's immediate telephone support. They do have, within limited hours, a mobile crisis team as well. It's a non-police led crisis team. So these are individuals who can go out and see somebody in the community. So that is available. We're working to try and expand those hours. But they're available most daytimes now, depending on staffing levels. So we think that's a really important service. So I have put the phone numbers there for the crisis lines. They are also available on our website. So please feel free to give them to your patients anytime. They can call 24/7. We also have, in collaboration with Durham Regional Police Service, two programs that I'm really proud of. One is our mental health support unit, and that is a team of nurses who work collaboratively with Durham Regional Police officers. They are accessed only through 911 calls. So other police would need to engage that team and say, hey, we need the mental health support unit to come on out. And a nurse and an officer will come together to calls that police are responding to provide expert mental health and addictions supports. And that's been in place for many years. I'm really proud of that team. We also have a collaborative with Durham Regional Police Service where we have a social worker who is embedded in the 911 call center so that call takers in the 911 center can put those calls over to our crisis call diversion program. We don't typically advertise that, so I'm just letting you know about it. Please don't direct people to it. They should be calling the call line directly. That's their best bet. We do have also through the Distress Center, Durham Suicide Survivor Support Groups. Backing up all of these crisis services, of course, we have our ED service, our crisis intervention teams. I'm going to tell you about that in a moment. But we also have amazing crisis homes in Durham Region. Right now, we have a crisis home that is available in Oshawa. It's just a little bit south of the hospital on Simcoe. And then we have another crisis home that's available in Ajax as well. And people can come there. You know, they usually have a short length of stay. It's about crisis stabilization. And you can find all the information just by taking a look at our website. You can direct your clients, can self-refer to it. They just have to call the call line and they'll help them to navigate to those homes as well. So they do overnight stay, crisis stabilization. They're a really excellent team. So I will stop there in terms of our community crisis care and take you to our housing program. Oh, our inpatient, I thought this was next. Yeah, our inpatient and emergency care team. We have been doing a tremendous amount of work around the emergency care experience for individuals across our hospitals. So we are in the actually very last year of a plan for mental health and addictions at Lakeridge Health. It's called Together Best Mental Health. If you're interested in that plan, you can find it again on our website. But one of the things that we heard very, very clearly from all of our partners, from primary care, from our patients, from our families, was that we had work to do in terms of mental health and addictions care. So we kicked off this plan probably about 3.5, almost 4 years ago, and have been working very tightly with our partners. So what informed that plan was a group, I hope many of you participated in that. It was actually before my time, where the feedback was gathered to say we needed to do this work and generated this plan. When we came back together, though, with the results, and I was able to bring the plan to our partners, we said to them, you know, there's some really good things and really important things that Lakeridge Health needs to do, but there are also things within this plan that are for this region to do. We don't think we should be doing this work alone. We think we would be better together if we did this in collaboration. And that group has stayed together now for the last 4 and a bit years to action many of the recommendations. And one of those is around emergency and responses to emergency care in the region. So we've been working hard in this space. I'm going to tell you a bit about what we've been doing. Much of our pilot work has been at the Oshawa site, and we are on a journey, and we are doing our best to improve that care experience. So at the Oshawa, so across Ajax and Oshawa, actually, we have crisis teams who are embedded in the emergency departments. They are not right now within the Port Perry or Bowmanville emerge departments, but those emerge departments know how to access our crisis teams very readily. We have a very strong collaboration. We work together. So at we have teams at both Ajax and Oshawa. They're crisis intervention teams. We have social workers, registered nurses. I'm getting there. Social workers, registered nurses, and child youth counselors who are a part of that team. We also have adult psychiatrists and child and youth psychiatrists who are a part of that team, as well as nurse practitioners. So we have a very robust team to support individuals who come into our emerge departments across the lifespan. Thank you very much for that question, Dr. Lee. So it's an across the lifespan approach. Within the EDs, we do our best to wrap around those individuals. We also have within those teams, particularly at the Oshawa site, we have peer support now, and that right now is Monday to Friday, but we're in the process of expanding that to weekends as well. So that's really important to us to have that peer support person in the emerge department proper. That's often the person who will keep somebody there. So we know that when people come into the emerge departments, they feel overwhelmed. They feel like perhaps what they're bringing forward isn't as important as what other people are bringing forward. They look around, it's a chaotic environment. They don't know what to expect. And we have seen amazing results come from having peer support directly embedded in the emerge. So really proud of that. We also have addictions navigators. We have both a hospital to home addictions counselor who supports, this is the opiate navigator that you see on the screen, who supports direct connection to addiction services in the moment in the emerge department. And we also have an addictions consult liaison team who supports there as well. And that's an addictions medicine specialist together with a nurse practitioner. And right now that team is available Monday to Friday days, and we're just in the process of expanding that nurse practitioner coverage in particular to weekends as well. And to bring it into the evening. So really looking forward to those expansions. Thank you to Ontario Health for their support in that. We have a hospital to home team, so they'll wrap around individuals in the emerge, make sure they're connected to services as best we can. At the Lakeridge Health Oshawa site, we do have a dedicated mental health and addictions emergency care space. You may hear people refer to it as Zone 11. It is a space that is specifically designed for mental health and addictions. Is it what we would envision for mental health and addictions? No, but it's something that we have that's safe. And I'm going to tell you about the vision that we have in a little while. It's a safe space. It provides a little less stimulation than what you would see in the ED proper. We have mental health and addictions nurses who are in that space together, partnered together with emergency department nurses. One of the really exciting things that we've worked on in the last year is to bring to Lakeridge Health. Right now it's in a soft launch period. So I'm going to put a caveat on that. So you wouldn't have heard about it. We haven't done the big splashy announcements or getting out there and letting people know. But we have done a soft launch of a bridging clinic at Lakeridge Health. So we probably about a year and a half ago partnered with the Center for Addiction and Mental Health. And they are doing lots of work with us that is so fantastic and supportive. And one of our first ventures with them was to replicate the KMH Bridging Clinic in Durham Region. So that clinic launched on April 1st. We have an interdisciplinary team. It is designed 4 needs within Durham Region. So a little bit different than the KMH model. We have addictions support embedded within that. We have chosen a lifespan approach. So we have our child and youth team is also attached to the bridging clinic. So that is a clinic that is operating right now just for 4 hours, 3 hours, Kevin.
Well, it depends what we're talking about because the nurses are available all day.
Yes.
Yeah.
Yeah, so it's, my point being, it's a limited service right now. So what we've done is used existing services to try and create this model. So we are going a bit slow on this, and I just don't want to overpromise what this looks like, but we're really excited by the work that they're doing now. So we have a broad team, nurses, psychiatry, social work, nurse practitioners, case managers, addictions counselors, who are wrapping around individuals who have been seen in our emerge department. So there is no direct referral pathway. It is only for individuals who have been seen in our emerge department. Yeah, so those are our crisis services, our emerge department services. We also have, oh yeah, go ahead, Kevin.
I'll just clarify a little bit on the bridging clinic. You may have said it, I might be repeating, I'm just making sure. I think the one main reason we have developed this bridging clinic is we were seeing many patients who are coming through the emergency room, some of them without primary care. Many of them have never accessed mental health services before, and their first time a mental health service was in the emergency room. And then what do you do after the emergency room visit? And so this bridging clinic allows for us it's a walk-in clinic Monday to Friday for those who have been assessed by our crisis team, and we can help with navigation and maybe some medication management, and we can provide some short-term follow-up to ensure they're linked to appropriate services. So that's really to fill that gap post-emergency service. I mean, we do hope to continue to expand this, but it's really filling an important gap that we're noticing. And there's a question in the chat, Beth, about can self-refer to DMHS crisis. Oh, you just answered that. Yes. So patients can self-refer to any of our crisis services. They can even show up at the crisis beds, and there'll be a team there to support them.
Absolutely. Can I just confirm that answered the question? Thumbs up. Okay, I'm going to assume it did. So in terms of inpatient service, we also have inpatient beds. At Ajax, we have both general adult inpatient beds. We have 16 beds for general adult and another 6 psychiatric intensive care unit beds at the Ajax site. At Oshawa, we have both general adult beds. We have 2 adult units. One is on C4, and that is a 23-bed unit, and the other is on A4, that's a 10-bed unit. We also have a 9-bed psychiatric intensive care unit at the Oshawa site. And specifically at the Oshawa site, we also have an 8-bed child adolescent inpatient unit as well. So wanted to make sure you knew about those. And they're accessed through the emerge department predominantly. We do occasionally have some direct referrals that can be admitted to our units through outpatient psychiatrists and people that they're following, but I will say it's pretty rare. Our demand for our inpatient beds is extraordinary. And, typically most individuals are coming into those beds through the emerge department. Right now, we're seeing about 40 individuals a day for mental health and addictions concerns through our emerge departments. That I will say is newer. That number is newer in the last month or so. We're seeing a lot of, I think some of the changes that are happening in the community are really impacting our visits, both around the toxic drug supply, as well as some of the changes that are happening in the shelter spaces. So seeing a significant number of people coming into the emerge departments and doing our very best to meet those needs with the resources that we have. So I'm going to turn to housing and tell you a bit about our housing program. So through the Durham Mental Health Services, we have a supportive housing program. It is a transitional supportive housing program. We have 7 locations, and our 7 homes range in support from low, medium to high. It includes a stream for both complex care patients as well as a formal collaboration with Ontario Shores around transitional forensic clients as well. So we do a lot of work in this space. Transitional housing is a space we've been in Durham Mental Health Service for a really long time. And I will say that waits for that housing program can be quite long. But you know, it's a really important service, and they do excellent work in helping people to build skills for community living and you know, really to prepare them ideally for independent living. But there's a few folks who go on to need ongoing supports in a permanent housing program. One of the things we're working on right now with our partners is where we may be able to work together in a permanent supported housing space. So that work is happening right now with our partners to see what might be possible. Just as a bit of an inside scoop for all of you. We do have a regional housing coordinator who is part of our team and does a lot of work around our unsheltered population. We do have an addiction supportive housing program as well, and we have a homeless rent support program. So we do have quite a number of rent supplements through Durham Mental Health Service as well. So it's a fairly large housing program. I would say Durham Mental Health Service and CMHA are probably the 2 biggest providers in this region around support housing programs. In terms of addictions, so we have a large addictions service, and we have a withdrawal management program at Pinewood Center that is on Center Street in Oshawa. This is a picture of Pinewood Center. It's a very large addiction service. It's I think 21 beds. So people can walk in anytime to get access to our residential withdrawal management service. I wouldn't say it's a medically managed withdrawal service, but we do have some nursing support that's on site as well. So people can walk in there anytime. We have a women's program, residential program as well. That's a 21-day program that's located in Whitby. We have an Umbrellas program. So Umbrellas is a program for substance using moms and is a really important program for rapid access to addiction service for individuals who are using substances. We have concurrent disorders day treatment programs. Our RAM clinic, Rapid Access to Addictions Medicine, has capacity every single day. People can call in, people can walk in. Very, very low barrier. They are located at 300 Center Street as well. And they also are at the Lakeridge Health Oshawa site 2 days a week. And their information is on our website as well. And we have a gambling, gaming, and technology team as well. Again, you don't have to remember all these things. All you have to remember is Central Connect, but I wanted you to know about this. I do have a few more slides to tell you about a few more services, but I wonder, given that Dr. Martins needs to step out, I think at 10:45, Dr. Martins, is that right?
11, sorry, by 11:40.
Oh, okay. Are you okay if I
Yes.
continue then?
Oh, absolutely, absolutely.
Oh, okay. Very good. All right. So we also have outpatient services, and we have quite a few that I think will be important for you to know about. So our eating disorders program, we have an outpatient eating disorders program. It is a program, again, that is a lifespan program. So you can refer adolescents, you can refer adults. It is one of our high demand services. They do a lot of amazing work. They have dietitians, they have psychotherapists, they have social work, nurse practitioners, psychiatry. So it is a very robust team around eating disorders, and we work very collaboratively with Ontario Shores as well in this space, and trying to make sure we get the right people to the right places at the right time. We do have 2 adult day treatment programs as well, and one is located at Oshawa, the other is located at Ajax, and we do have a transitional aged youth stream within those day treatment programs. So the day treatment programs are really for individuals, I would say predominantly anxiety and mood individuals who are like just holding on and, you know, are kind of on the verge of an emergency, the need for an emergency service. So they'll wrap around in an intensive day program and really provide people, you know, peer support, psychotherapy service, behavioral activation within our day programs. We do also have an early psychosis intervention team. This is a really important team, particularly for first episode psychosis. They've had a change recently. It used to be that first episode had to have been within the first year, and it has now expanded to being within the first 5 years, within 5 years. So, you know, they're following the provincial model and do amazing work in our early psychosis intervention team. And then we also have our adult integrated mental health service, which is a psychotherapy service as well, predominantly supporting anxiety and mood as well. And so those are our outpatient services. We have a very large case management program as well. And our case management program has lots of different components to it. I'm hoping most of you are familiar with assertive community treatment teams. These are teams that are available in the community. Our assertive community treatment team serves the Ajax and Pickering area, as well as a wee bit of Scarborough. It's an interdisciplinary team that has psychiatry, nursing, OT, social work, peer support, and they serve individuals in a very intensive way. So they will see people up to a couple of times a day. It's for individuals who have serious and persistent mental illness, so predominantly schizophrenia, psychosis, maybe some treatment-resistant bipolar. So they do very, very intensive service for long periods of time. So their criteria is very tight for who they serve. As I say, we do Ajax, Pickering, that Scarborough border, and then CMHA and Ontario Shores both have teams that support the remainder of Durham Region. We also have addictions case management teams who are available to provide addiction support, and that can be everything from you know, basic case management to addictions groups to we actually recently launched a psychotherapy service specifically for individuals who have addictions. We know that they often get excluded from many psychotherapies, so we have launched that within our suite of services as well. We have a general case management team with Durham Mental Health Service. We do have individuals who support with dual diagnosis, meaning developmental disorders. We have a senior support case management team as well. We have an Indigenous case manager. She is Central Connect trained. So if you think back to Central Connect, if somebody were to self-identify as being Indigenous or that was on their referral form, we would make sure we would have our Indigenous case manager be the one to reach out to them first. It creates safety for individuals who historically have felt harmed by hospital systems and healthcare systems. So it's really important to us that we have that Indigenous case manager attached to our services. We do have that homeless rent support system that I talked about before, and we have a very large peer support program as well as a family support program. And all of those are available again through Central Connect. You just need to reach out. We work very, very collaboratively with the courts as well. So across the court systems, we are part of drug treatment court. We have a concurrent disorders court. We participate in the concurrent disorders court diversion program. We have a youth addictions court diversion program, an adult court support program, a youth court support program. And we also have a release from custody program that works together with Central East and our partners here in Durham Region for individuals who have been incarcerated and are leaving custody. We know that that's a very high risk time, both for individuals from a mental health perspective, but particularly for individuals who have a history of addictions and perhaps have not been using while incarcerated and return to community and use, and it makes them extraordinarily vulnerable to overdose. So really important work that we do in release from custody, as well as pre and post diversion support at the courts. We have a robust child, youth, family program as well. We have outpatient care. We have a day treatment program. They are part of our eating disorders program. We do outreach in the schools. We have partnerships with all of the school boards to bring outreach into the schools for mental health and addictions. And we are part of the high-risk DAISY program as well, that school boards can activate for high-risk youth. So we have lots and lots of services. So that kind of wraps me up on our services, but I want to tell you a little bit about the work that we're doing right now that we think is pretty exciting. We know, so I talked about the experience that we heard about from our providers, our patients, our families, our teams. We know that right now, emergency departments have become the catch-all for many people. They are the first point of contact for many people. They, are environments that are very chaotic, very hectic. What we end up seeing are many individuals who will come in, present, and then leave without being seen. We know that particularly for our youth, our emerge departments can feel a bit frightening for individuals. And so we really want to create something that's different. I've already talked about the bright lights, loud noises, the competition for same beds with individuals who have medical concerns, the revolving door that's happened, the discharging back into the same conditions. That's some of the bridging work that we're doing. So together with our partners, we have a proposal in front of government right now for a robust mental health and addictions urgent care system, psychiatric emergency service, and an aftercare program. We're doing everything we can right now to lead into demonstration that will support that. So, you heard about all of our work at Oshawa around, the team that we have there and how we're wrapping around. You've heard about our work with the Bridging Clinic. That all ties to this. But it is a very large proposal. It includes the mental health and addictions urgent care, a hub and spoke model. So we will have a hub for the mental health and addictions urgent care at Oshawa with spokes that are out in the community, as well as having a mobile clinic that we will do in collaboration with our paramedic partners. And we'll have mental health and addiction supports together in all of those services. And right now we're doing some work around where those spokes might be. What do we want that to look like? We work together to design, we have been working together to design the psychiatric emergency service together with KMH. As I said, they've been amazing in offering us their expertise, their model, and really excited about that work. The Bridging Clinic is our aftercare approach. One of the things that's really important to us is that very, very tight connection to the emerge proper. So we know that there are times individuals present to our emerge with a mental health and addictions concern, and there is truly something physical underlying, and we need to be able to tease that out, and vice versa. People will come in with physical complaints, turns out it's mental health and addictions, and we need to be able to rule out and get to the correct cause to provide the right treatment at the right time in the right place. One of the things that we're excited about is the partnership with the Queen's School of Medicine, and perhaps down the road being able to offer some primary care support and training for primary care through these models. And together with Joel and Shannon and the work they're doing here, like really thinking deeply about how we connect all of this. So I wanted to share that with you. I thought it might be helpful just to share with you a little bit about who else is in this space. I know you're going to hear about Ontario Shores supports as well. But if not Ontario Shores or Lakeridge, where might somebody go? CMHA has amazing services for mental health and addictions. KINARC is a child provider. Catholic Family Services provides for children and adolescents. DCHC has fantastic services as well. Community Care Durham, the Heart Hubs. I hope all of you know about the Heart Hubs. There's 2 in Durham Region, 1 in Oshawa and 1 in Whitby, and they will have a regional approach. Certainly private psychotherapy is available, independent psychiatry practices, and we have many, many partners who are in this space. And one of the things we're really working hard on is trying to make it easy for people to understand how to access that. And I know Sarah's going to talk to you about Access MHA, which is really exciting and coming soon. It's here now, but she's going to tell you a lot more, so I won't get into that. And maybe I'll hand over to Dr. Chopra to talk about specifically our psychiatric consultations.
Yeah, thanks, Beth. So one of the areas we've been working hard in is increasing access to psychiatric consultations. So as many of you probably know, there were long waits for psychiatric consultations, which could be very frustrating for primary care, as well as obviously patients. And so we've done a lot of work on how do we improve access for that? So one of the things we do right now, and Beth mentioned, is through our Central Connect, really trying to match patients to the right service. So I think some patients may think they need a psychiatrist, but what they might really be needing is some other programs, case management, they might need psychotherapy. And what we found through our work through this triage is up to 40% of patients who referred for psychiatric consultations aren't really looking for medications. They're not really looking to see a psychiatrist. They're looking to get supports in the community. So through this work, we have now reduced our wait list at Lakeridge to about, I think it's about a couple of months, 2-3 months to get a psychiatric consultation. And whereas before it was over a year. So that's been a lot of work, and similar work, given I work at Ontario Shores, we have done similar work there. So access to psychiatric consultations has really improved in the region, and I hope the providers in the community are starting to notice that as well. Basically, during a psychiatric consultation, many of us, as you know, would look at diagnosis and management, and a lot of our work is navigation, trying to ensure patients are linked to appropriate resources, and then we often will provide recommendations to primary care on med management. Many of our services, to increase access, we often may only see a patient once or a few times and then transfer care to primary care. We do end up following those with the more severe symptoms or complex presentations. So I wanted to start there. I'm open to questions. We can do that later or now, but wanted to give some of the work that we're doing to improve consultation response times for the community. Beth, is there another slide after this?
I think it's Dr. Martin's now. Let me just make sure. Yep, Dr. Martin's is next.
Okay, so I'm going to be talking a little bit about neurodevelopmental assessments. I know that this is a common question that comes up. So the common ones that we see are for ADHD assessments and for autism spectrum disorder assessments. So I just, over the next few slides, I just kind of sectioned it into OHIP covered and not OHIP covered, and what are some of the options. So the first one regarding ADHD assessments, which have been, we've been seeing quite a bit of people either coming with for these assessments or already been diagnosed and having questions regarding treatment. So if the patient doesn't have a diagnosis, either the patient or primary care, they suspect it, couple of different options that can be done. So if the patient does have private coverage, that's probably the best bet, just because the given wait times and the amount of services that offers OHIP, because it is limited, which we'll talk about in the next slides. But if a patient, for example, doesn't have any private coverage and money is a significant barrier, this is the one place that I have been aware of that does OHIP covered assessments, the Focus and Function Clinic, and they're located in Pickering. So they also offer psychotherapy, coaching, DBT, CBT, but this is the one place that I am aware that will do this assessment that is OHIP covered. Next slide. And in terms of the private assessments, again, there's going to be a lot more resources available for this. So again, if the patient has private coverage through their work, or they are willing to pay privately, these are just a few places that I will mention. Again, we'll share the slides with everyone, so you all have this information. The one place I typically refer people mostly is Dr. Nicole Murray. So she's a neuropsychologist in Oshawa, and she's fantastic. I do know her personally as well. Very thorough assessments, does have extra training. So I do typically will send patients to her, especially if I'm not really sure if it's ADHD or a comorbid learning problem, intellectual disability. And as a psychiatrist, we don't do psychometric testing. So if I'm really feeling that needs to be teased apart, then I will make that recommendation. So her contact information here. Other places that I've heard of that are also quite good, integrated health services and flex psychology. Next slide. Maybe I'll just pause here for a moment before I move into the ASD if anybody has any questions about that. Specifically for ADHD assessments. Okay. So in terms of ASD, autism spectrum disorder assessments, again, very limited. So in terms of OHIP covered, CAMH does offer these assessments. That's the only one that I know of that does offer OHIP covered. Caveat is that it can be long wait times from my understanding of it. But again, this is something that if you have a patient not sure, you can certainly send in a referral through CAMH. Next slide. Okay, and again, a couple places here if the individual is looking for private pay. So this would be for a psychological assessment, and these are a couple places that I know that will do these type of assessments. Any questions about neurodevelopmental assessments, anything that I can answer? Certainly there'll be some time at the end, but just because I do have to leave a little bit early, I just wanted to open it up if anyone had any questions for me specifically. Okay, great. Send it back to Beth.
All right. So that brings us to the end of our presentation, which is great because I think it leaves us, 10 or 12 minutes for questions, conversation, feedback. Super happy to hear from you.
Shannon,
Perhaps
was
we
there
gave all the
anything?
information that no questions.
Yeah. Anything you had, Shannon?
Yeah, I think I was going to ask just a bit about, and again, yes, great talk. I saw that comment go in, but so much information. I think people just need some time to digest it sometimes. But one question I had, and maybe this will come a bit out of Sarah's presentation next, is I saw the slide was great about if not Lakeridge or Ontario Shores, then where? But how do we know Lakeridge or Ontario Shores? How do we differentiate between when and where? And sorry if I'm stealing Sarah's thunder a little bit on that one, but that was my burning question.
Yeah, that is an excellent question. And I think at this point, depending what services you're looking for, would probably be part of it. Psychiatric consultations happen at both organizations. Eventually, we want to get to a system, which Sarah will be talking about shortly, where there's one access point for Durham, and patients would be matched to the place with the lowest waiting time. So that is the future vision in the next year or two that is hopefully coming to Durham, and even it's a bit larger region than Durham, it's Central East. So that's one of the big provincial initiatives, because it's hard to know. And what we're seeing, which can be difficult, I know primary care just maybe sending sometimes referrals to both Ontario Shores and Lakeridge and saying whichever comes first. Yeah. And then we don't have a way of knowing who's had a consultation. So then some patients are getting 2 consultations and we're actually adding to the wait list. So it is a challenge in the system for certain services. I would say for some areas, we have specialty services. So addiction services are primarily based at Lakeridge Health. I'm getting, okay, I was just seeing if there's any other comments in the chat. We have a specialized borderline personality disorder program through Ontario Shores. So there are some specialty services. I think through Central Connect at Lakeridge, you could get a sense of, okay, the patient could find out exactly what they need, and then they could be navigated to the appropriate organization. And then there's other organizations like the Canadian Mental Health Association who do great work. They have case management services. So the goal would be to have one central access point, Shannon. I think you're answering the most important question, and which leads really nicely into the next conversation.
There's another one in the chat for you there. Do you want me to read it out? It says, do you know whether the OHIP covered clinics that do ASD and ADHD assessments provide virtual assessment options?
So for the ASD, so the only one that I know is CAMH. I don't know if they do it virtually. I think they do, but I'm not completely sure. So I mean, you'd have to find out. I think that I have seen some consults from them that it was virtually, but again, I don't know. That might have just been from the pandemic, right? And then for the ADHD assessment, so I'm not sure about the other two, but for Dr. Murray, I believe she does it in person because she does all the different scoring, right? So I think for that, like if especially if psychometric testing is done, that really needs to be done in person. Yeah, so maybe plus or minus the the SD, but for the ADHD, I don't know about the other two, but typically they would probably be in person. No problem. The other thing, maybe I didn't really talk about this, but if you have a patient who you suspect might have an intellectual disability, but there's no documentation, people might be familiar with that Developmental Services of Ontario, DSO. If you have a patient you suspect that does have a significant intellectual disability, but it hasn't been diagnosed, they can still reach out to the DSO. And if there isn't actual documentation, from my understanding is that they would still kind of help the patient go through some kind of a truncated assessment to see whether or not they will be eligible. And this is important because if an individual is DSO eligible, they would have support, right? There's passport funding, then that opens up to a whole other support services, respite, other types of services, behavioral support. So most of the people that I see are already connected, but sometimes, they aren't connected yet, or they are kind of aging out of the child and youth services, and it's not a clean transition from the youth service to the adult. So once an individual turns 18, they don't get the MCSS the services they had automatically go to the adult. So they have to apply to the DSO to get those services. So that's really important, and some people don't know that. So just wanted to put that out there because that's important too for those individuals getting the supports they need.
Amazing. And maybe I'll just ask a few more questions that often come up in our primary care WhatsApp chat. Maybe it'll be helpful for those on the call or those that'll watch the recording later. But I know primary care physicians often ask, if I send for a psychiatric consult, do they now have a psychiatrist? And then their mental health is now managed by the psychiatrist. And I think just maybe an opportunity to level set on expectations. Is it a one and done kind of consultative service, or is it, is there opportunity for ongoing psychiatric care and oversight typically in the programs that you offer? That's a question we see come up sometimes.
Yeah, I would say the way the consultation services work, partly to help move the demand in the wait list, is most patients we see are usually a one-time consult. Let's say the majority of patients can be navigated and provided recommendations to primary care. Those who are more severe and complex, and if through the assessment through the psychiatrist, I think we try our best to make a determination, is this best managed by a psychiatrist versus primary care? And those we would try to follow, at least for the short term. And some, obviously, with maybe more severe persistent illnesses, we would follow longer term. But what we do is we try to set, I think many patients do want a psychiatrist, and so we often have to have the discussion about what the role of a psychiatrist is compared to a therapist, compared to a caseworker. Many patients think a psychiatrist does therapy. You know, they see it in the movies, they see it on TV, and really saying, no, we're really more about the diagnosis, supporting medication management, and now therapy's done. There's a lot of now therapy resources, as we heard from the Ontario Structured Psychotherapy Program, which has been really beneficial for us. So, and then the other thing we have, I think it's coming up, are the primary care telephone consult service at Ontario Shores. I don't know if that came up yet, but we do have a slide on that. So what we offer at Ontario Shores is an opportunity for primary care to book a phone appointment with a psychiatrist. And we have availability almost every day. So if a primary care physician just says, I just want a quick question about, oh, they talked about it. Oh, thanks, Sarah. I missed that. Okay. But that would be the other option, is if you need a quick consult on a patient that maybe you weren't clear on the recommendations, or you're saying that I'm struggling with this patient and I need more support, that might be a way to access service and get more psychiatry support. Thanks, Sarah.
And then again, just open to the group. Please put in your questions in the chat or put your hand up. I don't want to take all the airtime, but I do know there's quite a few questions that I've seen come through the chat, in like from past months and everything else. But just wondering too about, you know, if there is a patient in crisis in a primary care office, you know, Beth, I think you talked about some of the crisis hotlines and things like that. But as a primary care provider, what, you know, how would you advise them or counsel them to support that situation and you know, get the patient to where they need to be in that crisis moment?
Do you want me to take a stab at this first, Kevin, and then you can jump in, or Jen?
Yeah, sure.
Yeah. So I think I don't think there's a one size fits all response to that question. It really depends on the degree of risk, the assessment of the person. You know, if you're significantly concerned, 911, ED are your go-tos, but the crisis services, the crisis beds are very, very, very supportive. So I think it's about having a conversation with the person around what they truly need in that moment. So like that would be my best advice. You know, you can give them crisis information. 988 is a fabulous resource as well. If you go on to the Lakeridge Health website that I talked about, maybe I'll put it in the chat. On the website, you'll see like all kinds of resources that are there depending on what's going on. But like I would say it's a judgment call for whether you're sending to ED, 911, or giving resources and saying, hey, you can walk into this crisis home. Hey, you can call this phone number. And it's the call line. Hey, there's a 988 number. Like it really kind of depends on the situation. I don't have a clear always this. Kevin, I don't know if you would add to that or wanted to add to that.
Yeah, the only thing I would add is I agree completely with all that, Beth. And then the other piece is sometimes you're seeing patients acuity, like you're seeing them and you're like, you know, this is going to be, they need to be seeing someone relatively soon before they end up in the emergency department. And if these are highlighted in a referral, we would prioritize them. So I know at Ontario Shores, those with severe depression, we have a mandate to see them within 1 week. And so we try to triage them. And similar at Lakeridge Health, if the Central Connect team is really concerned, they will book them in as a high priority consult. So there's that time where you're like, okay, I'm concerned about this patient and I think they're going to end up in emerge if we don't do something soon. You could use the phone consult service too sometimes, and you're like, okay, they're waiting for a consult, they're decompensating. And I've had that. I've had primary care call me and say, okay, I think they're getting manic. What do I do while I'm waiting? And then I can also try to expedite their consult into get them a consult very quickly. And then, of course, if you're just immediate risk and they need an assessment right now, then it would be the emergency room. And then some crises are more, you could call it based on social determinants of health, lack of housing, financial issues, maybe significant relationship issues. That's where I think the crisis homes and crisis lines can be really helpful, and they can get that psychosocial support versus going to the emergency department where we may not be able to support as much.
Maybe the one other thing too, I would add, it's not Lakeridge specific, but maybe, you know, for questions that are semi-urgent, the e-consult service. I'm sure a lot of everyone is familiar with that through the e-consult platform. So you can send e-consults to psychiatry, I mean, through any specialist, right? So also a very good way to ask questions, especially if it's about medications or other, you know, other questions that you have. And that's there, actually, it's a pretty quick turnaround as well. So that's always a great option to utilize. And I'm sure a lot of people are already on that platform.
The only other thing I would add is that, you know, that quick response that Kevin talked about really relies on good information coming in the first place. So just making sure if you have those concerns that it's flagged on a referral form is really important. And I know we're at time, Shannon. So maybe maybe we'll stop there. If that, I don't see any new questions in the chat, and super happy to connect with anyone anytime. And it was really nice being with you today. Thank you.
Amazing. Thank you all so much. That was really informative. Lots of great resources, and just huge kudos to the work and the responsiveness to the feedback that you've received, because I think oftentimes people give feedback and don't expect any change to happen, but really great to see that you've really taken feedback to heart and you know, made great efforts to improve those wait times and you know, address the feedback that was sent along. So thank you. Huge kudos to all the work that's been done by your amazing teams and yourselves. So that's great. Thanks again.